Thank you everyone for joining. It's 6:05. We'll start getting ready since we have a lot of things to get out of the way. First and foremost, my name is Kevin Giammi. I'm the marketing manager for Inova's sports medicine orthopedics department. I'll be monitoring tonight's question and answer section and chat, assisting with the interactive portion of today's program, and responding to any non-medical questions. Before we get started, I'd like to go over a few housekeeping items so you will know how to participate in today's event. First, all attendees are muted and your video is off. Note that the webinar is being recorded. Let me make sure of that. So we have something to share with everyone. It is excellent. And it will be sent to everyone who registered within a few days. We will also share it on social media as needed, and we will definitely include it on our website. You will have the opportunity to ask questions of today's presenter in two ways. The first is type your questions into the question and answer box, which can be done at any time during the presentation. Additionally, you can just throw it in the chat. Tonight, we're going to mix it up a little bit. Dr. Lingamfelter is actually going to answer questions at the end of each section. So kind of go over some material, open up the floor, and then jump into the next part. And then at the end of the night, any other questions that remain, we'll go through that. Just as a reminder, this is an informative talk only and not intended to replace your own physician's advice. In order to protect your privacy, ensure there's a thoughtful response, we suggest that you discuss the specifics of your medical condition.
It's okay. I can talk, one of the beauties of hybrid working from home and, in our home offices, sometimes we have extra participants involved.
Yeah.
So picking up where Kevin left off, let me minimize this just a bit. Sorry. Maybe here. The disclaimer. So purpose of the talk is generalized information that is not patient specific. All decisions regarding your personal medical care should be performed through a doctor's visit with your physician.
And that's a great segue. If you guys haven't met Dr. Max Lingamfelter yet, he's a fantastic surgeon. He's also a compassionate person and understood that I had a little kid running around. So that's a little bit of who he is. I think he's also got some little ones, which he'll go into. There are some other individuals on the call today that I wanted to bring up first, and then we'll jump in. We've also got two incredible nurse navigators. Hailing from Massachusetts, we've got Michelle Hall. If you want to give a quick wave, everyone can see her on the screen here. She's been a nurse for 15 years, Inova 3 years. And Michelle, which hospital are you? You're at Mount Vernon, correct? All right, so she's with our Mount Vernon Hospital. And then Brittany Smith is a nurse for over 16 years, has been at Inova Fair Oaks Hospital her entire nursing career. She's experienced in the recovery room prior to her role as a joint navigator and has lots of surgery background. And what's going to be nice is they're actually going to go through what they do and how they assist patients in the whole process, which is something we've never really gone over. And finally, Dr. Max Lingamfelter is an orthopedic surgeon, board certified. Excuse me. In orthopedic surgery, specializing in hip and knee reconstruction. Total joint replacement. So he joined Inova in 2024, has been practicing since 2015. And prior to Inova, Dr. Lingamfelter was actually at Kaiser Permanente Mid-Atlantic. His clinical interest areas include robotic replacement, joint replacement, and direct anterior hip replacements, which I'm sure he will go over today, as well as other complex and challenging revision cases. He enjoys working together with patients who are motivated by the desire to rebuild their mobility and independence after arthritis has eroded their quality of life. His patient care philosophy is based around a team approach, all perspectives that aims to help patients make a decision that is best for them, and they know because patients know their body best. Dr. Lingamfelter attained additional training through a prestigious reconstruction fellowship while at the University of Minnesota in Minneapolis, which included training on advanced skills in primary joint replacement surgery, such as partial knee replacements, direct anterior, and robotic assisted. So without further ado, I think I'm just going to go ahead and let you jump in, and I will come in later as need be. And thank you again for spending time with everyone tonight.
Oh, it's my pleasure. Thank you very much, Kevin. Thank you, Brittany. Thank you, Michelle, for joining as well. The work you guys do is just invaluable in helping our patients get ready for surgery and conduct ourselves safely and efficiently through the recovery process. So thank you very much. That was an awesome welcome, Kevin. And thank you, everybody that's joining at home. We really appreciate your time and choosing to spend time with us tonight and talk about hip replacement. So kind of the flow will be, we're going to have a section of lecture here for a second, and then we'll open it up for questions for 5 minutes or so if you have any questions about that, and we'll kind of go through the talk over the next hour and 20 minutes. If you need our contact information, I know there's going to be a link sent out at the end of the talk as well. But if you want to scan this QR code, that will give you my contact information as well. Oh, I haven't. Yeah, good job. Thank you. That's one of my unsponsored visitors here. Moving on. Let me minimize this so I can move it out there. So Kevin went through this already. We'll skip through that. So first of all, what is a hip replacement? A hip replacement basically is a treatment that is very successful for ball and socket arthritis that develops in our hips. And this is primarily manifested as groin pain, actually. So most of the time when patients are experiencing pain in their buttocks, it actually has to do with a different diagnosis, either muscular or tendinous, or even coming from the lumbar spine. And that's important, which we'll see a little bit later on as to why the pain manifests in the groin and not the buttock. It has to do with the anatomy of the hip, actually. So this is what mild hip arthritis looks like on X-ray. You can see that the ball is basically still pretty round. There's a separation of cartilage between the ball and socket, and that's what this dark space is here. It's a buffer protecting this hard surface from that hard surface. And basically what you're seeing here is that there's a little bit of narrowing that's occurring between the ball and the socket. And there are some subtle bone spur formations that are occurring on the outside of the acetabulum or the shell portion of the joint. By and large, the joint is still well aligned, and there's a little bit of what we call subchondral sclerosis, or I like to refer to it as scar tissue, which is evident on the bone via X-ray from the arthritis as the joint is experiencing more stress. So if you have an X-ray that looks like this, which is mild arthritis of the hip, by and large, the gait is unaffected. You'll probably walk basically normally. You'll have some groin pain, which manifests as, that's hip arthritis. And you probably will have some pinching pain in that region associated with specific range of motion, like flexing, bending over, bringing your knee up towards your chest, or prolonged activity, maybe walking more than 6 blocks or so. And when you have arthritis that looks like this, the treatment really is pretty simple. It's beginning out normal stuff, activity modification. So you want to avoid the activities that are irritating the joint and causing stress and pain. You can use Tylenol or NSAIDs such as Advil, Aleve, ibuprofen. Obviously, after agreeing upon that, and that it's safe with your primary care physician. Additionally, you could pursue physical therapy and weight optimization. Weight optimization is a really important part of this entire treatment protocol, because by reducing the amount of weight that our bodies are pushing down through this joint, it reduces the amount of stress that is experienced at each ball and socket joint. So this is what moderate arthritis looks like on an X-ray. That dark stripe of cartilage is becoming a bit more narrow, and that's what it means by progressive narrowing of the joint space. Those bone spurs are starting to become a bit larger, indicating more stress is being experienced by the bone as that cartilage buffer is worn down. And in this particular image, you can see how those bones are coming really close to each other, and it's almost bone-on-bone contact here. So the symptoms, if you had an X-ray that looked like this, the things you might be feeling is that when you watch someone walk with an X-ray like this, you might actually notice that they walk slightly unevenly. They would be experiencing pain with medium distance walking. So like anywhere from 3 to 6 blocks, this patient would begin to start feeling pain in their groin. Additionally, these patients will start to feel pain at night. Sometimes it'll wake them up in the middle of the night. Sometimes it will prevent them from sleeping the whole night. And it's very disruptive to their lifestyle for that reason. So the proposed treatment for moderate arthritis of the hip would be a cortisone injection. We have ultrasound specialists at Inova that actually use an ultrasound to help localize this little space here. And we put a small amount of medicine between the ball and socket to help anesthetize that region. Similar to when you have a sore throat and you take, a steroid dose pack, it's like a tiny little amount of medicine between these two spaces, and it helps calm down the inflammation and pain for the patient. You could also consider a higher dose NSAID, so something like meloxicam or Celebrex or something like that, which would be managed by your physician. And you could also consider a cane. And when you have say for example, if you have right hip arthritis, you actually want the cane in the opposite hand. You would put it in the left hand because it's actually the hand opposite to the hip that's hurting that would help offload the joint most effectively, which is kind of counterintuitive. And then this is what severe arthritis looks like. So now you can see that the ball and socket are very intimately associated with each other. That joint space of cartilage has basically whittled down to almost nothing. And there's nearly circumferential contact between the ball and the socket. So there begins to be a slight change in alignment where the leg becomes shorter. You will see more significant cyst formation around the head and the socket. And you will see large joint spurs, which are beginning to limit range of motion severely. So this hip here, for example, would have very minimal rotation or flexion associated with it. The way this would manifest as symptoms would be a severely affected gait. So if you saw this person walking from 20 feet away, you would be able to tell that they're walking unevenly. They would have really significant sleep disturbance, which ruins quality of life. And frankly, is one of the most common reasons that patients come to the clinic is sleep disturbance, and very limited walking. They could walk maybe 1 to 3 blocks before this pain is really forcing them to stop. So the proposed treatment at this point would really be considering surgery, like a hip replacement. You could also consider using a walker or a cane for patients that are not medically stable enough and healthy enough to undergo an elective hip replacement. That's basically the recommendation, is you got to use a walker to take more stress off of the hip. When the walker is no longer successful, unfortunately, you would have to transition to a wheelchair at that point. You could consider a repeat injection. It's kind of a temporizing measure, if you will. It's kicking the can down the road. It's not going to fix the problem. No amount of medicine is going to fix the structural issue of the hip. But if we need more time to optimize what we call modifiable factors preoperatively, your social support, what family is around, what time of year is it for you and your family? Are you busy with travel? Is your work busy during that time of year? If you need to, move surgery further down the road to optimize those factors and make sure we're giving you the best possible experience for the operation we can, then we could consider a repeat injection, although we acknowledge it's not going to fix the problem, unfortunately. Alternative therapies that you could consider if you wanted to try literally everything under the sun, and these are kind of adjunct, somewhat helpful therapies. So there's something called cognitive behavioral therapy. And what is that? It's basically a specific type of therapy where we are trained to analyze our pain in a different way cognitively. So we are trained to register that sensation of pain, change the way we think about it, and help regulate the emotional, parts of being in pain, which is really difficult. And studies have shown that can actually be quite helpful for arthritis in the long run, both hip and knee arthritis. And I was kind of shocked by that, but the literature does support that as a therapy in the long run. Tai Chi, actually, shockingly, has been demonstrated to be helpful in reducing arthritis pain. And I think really, if you think about it, it's basically physical therapy. It's stretching your muscles, it's providing strength training in a very slow, cautious, safe manner. It's testing out range of motion and improving range of motion. And there's also a breathing and meditative component as well. So Tai Chi, surprisingly, has been shown to be helpful in treating hip and knee symptoms. Another thing that can be considered is dry needling or acupuncture. Some patients swear by glucosamine and chondroitin. This has been studied ad nauseum, and the data basically shows it doesn't hurt to take it, but we can't say definitively that it helps also. So some patients find it very helpful. Other patients feel like they're taking nothing, but it certainly won't hurt to try. And the very last thing I include is kind of supplementary, but if you really wanted to try everything you possibly could to improve your joint pain, one of those things would be a low glycemic diet or an anti-inflammatory diet, which would include turmeric supplements. And unfortunately, removing all the fun things out of our diet, like pasta, cereal, carbohydrates, basically bread. All of those things have been shown to increase inflammation in the body and can result in increased symptoms related to arthritis. The treatments that are not strongly supported through various studies are PRP and stem cells. So I wish there was an injection that would be helpful at treating this problem. There simply isn't. So PRP and stem cell therapy is an injection into the joint with a certain amount of material, and unfortunately, due to the nature of the joint itself, it is simply not effective at treating arthritis. And you can see why after looking at those x-rays of the patients. No amount of medicine or PRP or stem cell will be able to fix the structural problem of joint degradation, which is the cartilage wearing down over time. Additionally, even in the early phases, it's not really helpful because this is an example of a knee, but the same phenomenon is true in a hip, which is there's a capsule called synovium, and the synovial tissue surrounds the joint, and it keeps fluid inside of the joint so that it's lubricated. And every time you move your knee or hip, those two surfaces are rubbing back and forth, and that fluid is being circulated. So there's no way to really hold PRP or stem cell to any significant concentration in the small areas of cartilage degradation, because that fluid is continuously circulating almost like a hot tub, and the PRP and stem cells simply float to other parts of the joint. Additionally, when you have two hard surfaces like a cartilage damage and a cartilage damage here rubbing on each other, that simply evaporates that stem cell and PRP from the location that it needs to be in to solve the problem. And for that reason, PRP stem cell is not advisable and does not fix arthritis, unfortunately. Another thing people ask about are shoe inserts. So this has been studied considerably over the last 20 to 50 years. And unfortunately, shoe inserts have not been demonstrated to significantly affect or improve arthritis symptoms in the hip or the knee. A couple last things, laser treatment, you'll hear about these things on the TV or on the internet. And the reason that insurance doesn't pay for any of these is because they simply don't work. So these have been studied pretty closely, and laser treatments around hip and knee arthritis have not been demonstrated to be any more effective than placebo treatment, unfortunately. And maybe at some point in the future, one of these things will prove to be successful and really meaningful, but so far to date, none of them have. The last thing is hip arthroscopy, and that simply means putting a tiny little scope into the hip joint and trying to manipulate the cartilage and the ligaments and the labrum to help solve problems. So that is an option for patients that have sports-related injuries in their teens and 20s, maybe 30s. But once things progress onto this circular feedback problem, which is arthritis, there's no way to successfully treat arthritis with a scope, unfortunately. So for that reason, those treatments are not recommended. And now, if we could take maybe 5 minutes, Kevin, and open it up for some questions, is that all right?
Yeah, I think the first one is, do you mind elaborating on PRP? There was a question of what that was.
Yeah, absolutely. So PRP is a concept where we take your own blood and we spin it down in a centrifuge, and it concentrates the amount of cells in the bottom of the test tube, basically. That concentration is red blood cells, white blood cells, and autoimmune factors that are helpful in the healing process. So say, for example, you have a tendon injury in your shoulder or your elbow, and that it's not inside of the joints, it's in a different part of the body. By taking those cells and injecting it in the area that is damaged and trying to recover, it can basically turbocharge the healing capacity of those tissues. It's great for problems that are not bathed in synovial fluid, because that synovial fluid continuously circulates and washes those things away. So it can be helpful in certain muscle injuries, but unfortunately is not. Oh, I think Mommy has your helicopter. Yeah, sorry. So sorry about that. So unfortunately, it's not helpful in treating hip or knee arthritis.
So I think we got a few questions about cortisone and injections. There was something about in the chat about cortisone has some funny side effects. Is there anything else? And then what is the alternative to cortisone injections if you can't have steroids?
Great question. So the background on steroids treatment is that everybody's afraid, and I understand, of what cartilage degradation and destruction of the joint by repeated cortisone injection, and that is a concern. And that concern came basically from the 80s when these NFL players were getting injections every Friday night in their knee or hip before the big game, right? So they could go out there and play. And it did result, okay, all right, thank you, buddy. So it did result in cartilage wear and tear for those patients that got injections every week. And for that reason, we don't do injections except every 3 months. And by that time, it's entirely safe, and the medicine has, made its way out of its system, out of your system, I should say. So by doing injections every 3 months, it's a very, very safe mechanism for controlling arthritis in your knee or your hip, because we're not doing injections every week, we're doing injections every 3 months. And by the time 90 days rolls around, the concentration inside of your joint has decreased to such a point that it's almost immeasurable. And that's why it's safe to do it like that.
We're also going to
Oh, sorry.
definitely
I
have
was
some.
gonna
Go ahead.
go ahead. Alternatives for steroid injection if you can't have it. So there is this concept of hyaluronic acid. It goes by many different names, but gel injection, hyaluronic acid, rooster comb, these are all basically variations of the same concept, which is we're trying to inject a lubricating substance into the joint to decrease friction and pain. And that is an alternative for steroid in the knee. Unfortunately, gel injections are not FDA approved for the hip joint. So it's not a useful treatment as of right now for hip arthritis.
And that's great to hear because we do have a lot of neat questions as well. And I think one of them, let's see. You mentioned arthroscopy for hip wasn't recommended, but for knee problems, is that helpful?
It is not. Once you reach the phase of arthritis, so to speak, that means both surfaces of the joint, both the knuckle and the receiving portion, are becoming uneven and jagged. And that means that, you can't really fix that with a scope. If you have an identified, simple, and singular meniscal tear, then that can be addressed with a scope procedure to remove the portion of the meniscus which is irritating the knee. But once arthritis sets in, it's a circular feedback that results in more and more wear and tear. And unfortunately, that cannot be fixed with an arthroscopy or scope procedure. Generally, meniscus tears prior to arthritis can be helped with surgery, with scope procedures. Once arthritis sets in, scope procedures are unfortunately off the table.
Okay. And then I think we've one more question: how to tell tendonitis versus arthritis?
It's a good question. So tendonitis generally will be improved with topical creams. So if you had tendonitis and you use something like Voltaren cream, Icy Hot, Bengay, Tiger Balm, anything like that, and that penetrates deep enough to reach the muscle and tendon, or tendonitis, I should say. If that improves your pain, then it's more likely to be tendonitis. But the ball and socket portion, either of the knee or the hip, is very unlikely to be improved with topical creams. So that would be one way to tell. Another way is simply go see your doctor, and they'll get an x-ray of your joint and tell you whether or not there is progressive arthritis based on the x-ray, and that would answer the question as well.
So we do have a lot of excellent questions still left, but I know that they fit in better in the portions you're about to answer, and including there's a lot of questions, Michelle and Brittany, look out for our nurse navigators that I think are going to be great for both of you. So Dr. Lingamfelter, let's jump into your next portion. And there's a great question that might lead into it. Is there a tipping point at which you and or your patient conclude that a hip replacement is the best action to take? So let's maybe that's our segue.
Absolutely. Yeah. So when you've exhausted all those other things, you've tried NSAIDs, if you're, if it's safe for you medically speaking, if you tried NSAIDs and that's not doing it, if you tried Tylenol, if you tried activity modification, and you tried a steroid injection, and none of those things are working, then it's time to consider a hip replacement. I always tell patients that, if it's not terrible, terrible bone-on-bone arthritis, a steroid injection can be helpful for two different reasons. Number one, it can help solve the problem and treat the pain. Number two, it is testing the joint to tell us how severe and advanced the arthritis is. If the steroid shot does not fix the problem, it tells us we got to move on to the next phase of treatment, which is a surgical reconstruction. So perfect segue into the next part of the talk, which is what is a hip replacement? This is a picture of a hip replacement. And let me go, hip replacement, just to lead off of things that don't work, a hip replacement really works pretty dang well. So it has been dubbed the operation of the century by the medical community due to the impact that it can have on people's lives. And that's why it is such a joy to be able to, provide this service to our patients, because it is truly a life-changing operation for the better. And what is a hip replacement? This is a diagram of a hip replacement showing the red arthritic bone, which has been damaged from the wear and tear over the years, and the cartilage degradation exposing this irritated bone, which occurs on the ball portion and the socket portion. We remove that bone which has been damaged from the arthritis and replace it with a new hip reconstruction composed of a ball and a socket. There's a metal shell called an acetabular shell, which goes into the pelvis. Then a polyethylene hemisphere is inserted into that. The polyethylene serves as artificial cartilage between the socket and the ball. The ball sits on top of what's called a femoral stem. I like to describe it as like a fence post, because everybody knows what a fence post is, and it goes down and it lives inside of the femur and it stays there for the rest of your life, and you never know it's in there. These components are held in place by what's called grit fit or press fit. Historically, cement or screws were utilized to hold the shell in place here, or the stem here would be surrounded with what's called a cement mantle, and the cement would hold the metal component next to the bone. And that was successful up to a point, but we noticed that over time, over 15, 20, 25, 30 years, it was actually the cement that failed more than the metal or the plastic. So nowadays, we use this special material called trabecular metal, and this is a picture of what it looks like. On the undersurface of the cup and the stem, it's coated with this material that results in what's called on-growth. And this material was designed by metallurgists by looking at bone under a microscope. And if you look at bone under a microscope and this metal under a microscope, it actually looks quite similar, to the point where the bone cells on a microscopic level detect that similarity. And over your healing process of 6 to 8 weeks, the bone actually grows onto the femoral stem and onto the metal shell, such that it becomes a part of your body. And that takes about 6 to 8 weeks usually. And that's how the components are held in place. And then another part of how hip replacement is achieved is what approach is utilized. So you've heard a lot about, perhaps having done any reading about it, you will have heard about anterior versus posterior hip surgery. And really what that means is, where is the incision going on the body? Is it going on the buttock region, or is it going in the front near the groin? Traditionally and historically, hip replacement was done through a posterior approach. And that's how hip replacement was developed, starting back in the 50s and the 60s. It has been known as the workhorse, and, historically, that's the way it was done. But we discovered over time that actually, by doing surgery from the front through what's called an anterior or a minimally invasive approach, we can improve the outcomes of the surgery. And I'll show you why that is. So to kind of describe the difference, this is an MRI image of your ball and socket joint. So this is a patient that's laying down, for a direct anterior hip replacement. And imagine this MRI scan is like, a loaf of bread, and each part of the body is a different slice. Well, this is the slice that is taken from the ball and socket joint right where we're working to do the hip replacement. And as you can imagine, if you want to, let me bring that pointer back here, laser pointer. So if you imagine approaching the hip from a posterior approach, where the incision is placed on the buttock, you have to go through a very large muscle, which is the biggest muscle in your body, your gluteus maximus, and also your IT band, in order to get down to the hip and replace it. Additionally, you can see that the cup is actually leaning forward. If you look at which way the cup is facing, or the socket, you can see that the socket is actually facing forward. And that's why anterior-based hip surgery is actually the most amenable way to get down to the hip and replace it without disrupting very much muscle. So from an anterior-based approach, we don't have to cut any muscles to get down to the hip joint. We simply spread these two small muscles apart from each other, and we go through this space right here, which is a clear and open space. And the beautiful thing is, at the end of a hip replacement from an anterior approach, you take out the retractors, and these muscles just come back together like a theater curtain, and we're basically done. Um, so that's one reason why an anterior-based hip surgery is more successful in an easier recovery for the patient. And remember, we said back at the beginning that when ball and socket arthritis or hip arthritis is manifest as pain for the patient, it actually appears in the groin most frequently. And you can see based on this MRI image that the hip is much closer to the front of the, kind of like where the belly button is, it's much closer to the front skin than the back skin because of all the soft tissue that is separating it. So it makes the recovery much easier for the patient. So that's bullet point number one. It results in a faster recovery, which has been demonstrated in almost every study that has analyzed anterior versus posterior surgery. It results in more accurate leg length recreation. And the reason is that when you do anterior-based hip surgery, the patient is laying in a more natural position, which is flat on their back and their legs are out straight. When you do posterior-based surgery to get into the buttock region, you have to actually turn the patient on their side and have them lay in this position with these supports here. And it's very difficult to judge leg length from this position, as you might imagine, because this leg is straight and this one is hanging down lower on top of the other one. Additionally, when we do anterior-based surgery, there's a machine called a fluoroscopy machine. It's basically a really souped up X-ray, and it provides live digital snapshots of the hip replacement at each step of the procedure. So we can verify that all the components are going exactly where we want them to go, and that we are recreating the leg length most accurately for each individual patient. That is a much more challenging prospect when you're doing it from a posterior approach. So that's one reason why anterior-based surgery is generally more successful in achieving equal leg lengths. Another really significant thing for me and the patient is that there are no precautions after anterior-based hip surgery. And the caveat is that, you've probably heard of patients or surgeons or friends that had a posterior-based hip surgery and they couldn't bend over and, tie their shoes. They couldn't pick up their keys if they dropped them. They had to have one of those grabber things. They needed a higher toilet seat. They needed a higher chair to sit in. They couldn't cross their legs. When they slept at night, they needed a big pillow. They needed to sleep on their back. So those are all things referred to as precautions, rules that you have to follow after you have a posterior-based hip surgery. And the reason is that to get down to the hip from a posterior-based approach, you have to release a lot of muscle. And it basically destabilizes the hip because you have to bring the ball to the back portion to fix the socket or to fix the hip and put it back in place. And that destabilizes the hip when you go in through a posterior-based incision. All of those precautions have nothing to do with anterior-based surgery. So from day one, as soon as my patients wake up, they can basically do anything they want to within reason. I want them to be safe and cautious, but there are no precautions for 99.9% of my patients because of the added stability that comes along with anterior-based hip surgery. So they can bend over, they can cross their legs, they can sleep on their side, they can basically do anything they want. And my only rule is, as long as it doesn't hurt, go ahead and do it. And for that reason, there's a reduced dislocation rate when you're doing surgery from an anterior-based approach. There's a reduced risk of postoperative limp because you're not damaging as much muscle. And also you have more accurate leg length recreation, which is required for equal walking. The incisions tend to be much smaller because you have direct access to the hip instead of having to go through all of the soft tissue. And all of these things combined result in a much improved patient satisfaction and patient experience around hip replacement. So this is an example of an anterior incision, and this is an example of a posterior incision. Posterior incision goes along the buttock and the side of the leg. Anterior incision goes along what we call the bikini line, if you will. It's not actually where the bikini would go. It's actually right below where the bikini would go, but they just call it that. And for that reason, the incisions tend to be smaller and they tend to heal much better. You can sleep on your side right away with anterior-based hip surgery. As you can imagine, sleeping on your side with this incision probably would not feel very good and generally is not recommended by surgeons that do it this way. So that is the conclusion of that section of the talk. Do we want to open it up for questions for a few minutes?
I think we certainly can because we have quite the questions. So
Okay.
why don't why don't we jump into a few of them?
Okay.
Um, let's do
Kevin, I was taking note of a couple if that would be helpful.
great.
Yeah. So Dr. Lingamfelter question was, when you're talking about robotic joint replacements, is this done by a robot or you, the surgeon?
That's a great question. I am doing 100% of the operation. So the robot is actually a measuring tool that enables the surgeon to be more accurate. And we actually have a section on that coming up, but the surgeon is always in charge of the procedure. The robotic system is merely a measuring tool that makes us more accurate.
Okay. Can you explain when a partial versus a total joint replacement is recommended? And this would go for hips and knees.
Yeah, absolutely. So in hip replacement, unfortunately, there's no such thing as a partial joint replacement because it's really just one articulation. There's one surface touching this surface. In a knee, it's a bit more complex, actually. So there's three compartments to every knee. There's one compartment to every hip. So that's why partial replacements, unfortunately, are not applicable to hip, but um, partial knee replacements are a possibility. And let me see. I think I actually have another talk that has a picture, might be at the end here. Stock slides, right here. So this is what a total knee replacement looks like. It's resurfacing 100% of the end of your femur and 100% of the top part of your tibia or your shin bone. A partial knee replacement is a possibility. Find that picture. I think it's in a different lecture here. Sorry, just one second. A partial knee replacement is an option when only one of those three components is worn down with arthritis. So this is what a partial knee replacement looks like. It's generally for younger patients that are more active. So the different parts of a knee are the inside or the outside knuckle, if you will. And then this trochlea component where the kneecap lives and travels up and down. So it's one, two, three different compartments, if you will, of a joint. And that's why knee replacement is a little bit more complicated than hip replacements, actually. So if your arthritis happens to only involve one of these three components, why would we replace all three of them? I mean, that's basically what a total knee replacement is. There are certain pluses and minuses to both options, but if your arthritis only affects one of those components, then we have the option of just doing a partial knee replacement. Another example of a partial knee replacement would be this. This is called a patellofemoral replacement. This is one of my favorite operations to do because patients tend to recover very fast from it. Unfortunately, it's only applicable in certain clinical scenarios where the arthritis is purely behind the kneecap. So patients that have pain with squatting, with going up and down stairs, with getting up from a seated position, or any position where the knee is flexed, that generally indicates patellofemoral arthritis, and we're only replacing the portions of the knee which are damaged by arthritis, which would be behind the kneecap and the groove where the kneecap lives. The two weight-bearing surfaces of the knee, the inside and the outside, those are left untouched because the arthritis has not, affected that joint yet. So those are the two options for partial knee replacement: is a patellofemoral replacement, which is the kneecap and the groove, or a medial or lateral joint replacement, which is like one of the weight-bearing knuckles, if you will.
Sorry, I think we got a little bit ahead in your presentation talking about knees.
It's okay.
There were some questions about knees specifically. Do you want me to wait until we get into that topic, Dr. Lingenfelter?
Yeah, if
Okay.
that's okay.
One other just general question is, what is the joint replacement implant made out of? The ball and socket portion.
Great question. So historically, there was some amount of stainless steel in these components. And one of the questions I get all the time is like, do I need a card to go through the metal detector at the airport? And the answer is no, not anymore, because they are no longer made out of stainless steel. They're actually made of titanium now. And so this metal component is made out of titanium and cobalt chrome. as well as the acetabular shell or the socket portion. The balls used to be made out of metal and primarily cobalt chrome. Now, modern technology actually is such that the reason this ball is pink instead of silver and gray is that the balls are now made out of ceramic material. So if you look at metal versus ceramic under a microscope, even though metal appears smooth to our eye, when you look at it under a microscope, it can be a little bit uneven and jagged. That results in increased polyethylene wear and thinning of that artificial cartilage over decades. Where if you switch that metal to ceramic, which even under a microscope is like perfectly smooth, it reduces the wear of the polyethylene over the decades by making the surface even more friction-free. So basically you have titanium, cobalt, chrome, polyethylene, ceramic, and then more titanium and cobalt, chrome.
Thank you. Another question is, how is the hip approach determined? So anterior versus posterior, how would that be decided?
That's a great point. So 100% of my patients for what we call primary surgery, or like the first time they're having surgery on their hip, are done from an anterior-based approach. It's my personal choice, and obviously I feel very strongly about it, that provides the best outcome for the patient. Occasionally, there are patient factors that would prevent us from doing an anterior-based approach, and that's not really so I'm giving you the opinion of the other type of surgeon, I guess I should say, which is there are some surgeons that feel that anterior-based incisions can only be done on patients that do not have a lot of soft tissue in this part of their body. So if and that's not my opinion, that's actually I do 100% for an anterior-based approach, but if you go see a surgeon and they say you're not a candidate for an anterior-based hip surgery, it's usually because there's a big tummy right here that's going to sit down on top of this where this incision is and potentially cause a problem with wound healing or infection. I don't think that's the case. I think as long as this area is clean and safe and there's no prior surgical incision, there are specialized techniques that you can use to make this incision safe for almost every patient.
Okay, one more, and then I'll let you continue your presentation. Okay. How long does the joint replacement last?
That's a great question. So the hip replacements that were done historically, so say, for example, the ones that used like cement and screws, those lasted anywhere from like 20 to 30 years. And that's, again, because the cement mantle would break down over time. These modern implants that use what's called on-growth technology, where the bone grows onto the implant, have been outlasting those implants, the older style implants. So we forecast that these newer types of fixation will provide hip and knee replacements that should last at least 20 years, if not much longer. And it's simply because, this technology is relatively new, with really promising early results, but we don't have enough data of these things actually failing yet to tell you how long exactly they're going to last, but they should last at least 20 to 30 years.
Excellent. I think that wraps up this group of questions, but just know we do have a nice list going, and everyone, we will try to get every question by the end of the night. We have plenty of time left. So if you haven't heard an answer to your question or us even address it, know that I've got a nice little list in a Word document. We will get to it.
Sure. All right. So the next part of the talk is about robotic hip replacement. So this is a new hot button issue. Robotic joint replacement was developed over the last 10 to 15 years. Mako is the longest and most successful track record of robotic applications in joint replacement, and that's why I use their system, as they have the most well-established track record. So what is robotic hip replacement? Basically, the concept involves getting a preoperative CT. The CT gives us a three-dimensional model of your unique anatomy. So everybody's bones are truly slightly different shaped, oriented in slightly different positions. They're bigger, they're smaller. There are slight little minute details that we can plan for during the operation by getting this preoperative CT for robotic hip replacement. It results in an image such as this. So this is an actual real life pelvis of a patient. And that enables us to plan the operation exactly, perfect for that patient. And we can actually do the operation on the computer software before we even make an incision in the operating room. It's really remarkable technology. So that's what's called 3D planning. So we can plan the surgery in the computer system and know how it's going to turn out before we even start the operation. It's really cool. It's kind of like knowing the answer to the quiz before it even starts. It allows us to calculate the exact size of the acetabular shell and also the femoral stem that's going to go down inside of the femur, so we can be prepared for exactly the right size that we need. It can also calculate it such that we're minimizing the amount of bone that's being resected on the acetabular, the cup side, and also the perfect size femoral stem for your unique anatomy. So we get to know what the sizes are before the operation starts. Another really key component of hip replacement is what's called leg length and offset. So basically, these are two measurements that are calculating exactly where your leg is relative to your pelvis. And it can either make your leg longer, shorter, wider, or skinnier, to put it simply. But basically, those are measurements describing the position of your femur versus your pelvis, and it's unique for each individual patient. So we take what we see on the preoperative scan, and we are able to develop a preoperative plan that recreates these numbers of leg length and offset precisely for every patient. And then the last part of this process is during the operation, we have tools that actually verify the outcome to make sure that we got exactly what we planned for. And what that results is very accurate leg length outcomes. So this computer software combined with the preoperative planning, we go in there, we execute the plan, and we ensure that when you wake up, your leg feels like it's exactly in the same position as when you went to sleep using this technology. We mentioned that it preserves bone with regards to the acetabular shell because we know exactly what the perfect fit will be. This results in improved ligament and muscle balance because if we reconstruct this hip and put it exactly where it was when we started, then we know that all the muscles, tendons, and ligaments that have been living there in your body for your whole life will really like the new hip as well, and you'll basically hit the ground running. So that by recreating your unique leg length and offset for each patient, it results in a much more natural feeling hip. And all these things put together basically mean that the patient satisfaction and the patient experience is really tremendously improved. So this is an example of a robotic hip replacement that I did on the right side where we were able to exactly match leg length versus the left side. We're also able to maximize head diameter, which improves range of motion and stability as compared to the previously done manual hip. Any questions about robotic technology or any of those topics so far?
I think the robotic one is pretty good to go. You can keep heading along.
Okay, so the next iteration of this technology and technologies in general helping us do joint replacement better and better every year or every decade is what are called artificial intelligence and really advanced software packages in hip replacement. And I'll show you how that works here, but it's really exciting stuff. So as the surgeon is doing the operation, we have that live digital fluoroscopy machine, which is taking pictures, and those are projected onto the screen to enable the surgeon to be as precise as possible. As these images are captured, we feed that information into a software package called OrthoGrid. There's another one called Velis, very similar. And basically, it analyzes these pictures for us down to the millimeter level. So with robotic hip replacement, there's a couple different checkpoints that we use to verify we're getting the outcomes that we want. Sorry. Okay, go show my.
And I just want to remind everyone, I just put it in the chat, but Dr. Lingamfelter just actually wrote a nice blog article on a little bit about AI and the other tech involved in joint replacement, and I put that in the chat for everyone to take a look at.
About that. Thank you, Kevin. So it's really fascinating technology, and basically by taking these images from the live digital x-ray, feeding it into the software. Instead of having a couple different checkpoints, which is what we have with robotic technology, it results in checkpoints that are created all along this bony surface every millimeter. So you really have like hundreds of built-in different separate checkpoints, ensuring that we're getting the hip replacement as precisely placed for your unique anatomy. This software was actually trained on over 1 million hip replacement cases. So you may have read or heard about artificial intelligence and software packages that are able to detect cancer screens much more sensitively than a physician and his eyeballs, or an EKG reading software that's much more sensitive and able to detect abnormalities in the rhythm of the heart than a cardiologist. So that's what it's providing for us now, is we're feeding it this live digital fluoroscopy stream of images as we're doing the hip. And this software has been trained on over 1 million procedures, and it gives us input and quantitative data to say, this is how the result will be if you make a slight adjustment here or there in order to make the most accurate hip replacement for your unique anatomy. The difference between robotics and these software packages is that you don't have to get a preoperative CT, so it's less radiation for the patient. When you do robotic hip surgery, you do have to use a checkpoint or a safety marker on the other side of the hip, which is called a pin. So you don't have to do that with these newer AI-driven software packages. And you also don't have to have as much of an exposure, because when you're doing robotics, you have to register the software map of your bone onto the real bone. And you do that by using a small probe that creates a map of the pelvis, and then the software is mapping that virtual image onto the real image. That's not necessary with the new software packages analyzing these digital images. So you don't have to do all the registration, which results in a smaller exposure and less tissue, which is, involved in the surgery. It also results in shorter operative times because it's eliminating steps that were necessary with robotic technology. So both are great ways to do hip replacement. Both of them have excellent outcomes. And, when you talk to your surgeon, you should weigh the pros and cons of both methods and figure out which one is best for you. But by decreasing the operative time, you can decrease the amount of anesthesia that the patient would be receiving to conduct the operation. So this is an example of one of those live digital fluoroscopy streams, which is, this person is having a right hip replacement. It's a 50 millimeter cup, and they're being given this feedback from the software system, which is the leg length is 2 millimeters shorter than when they started. So that means the surgeon can go in and adjust this ball size to increase this by 2 millimeters and make it exactly perfect for the patient. So it's a way of providing live digital feedback and quantitative information that the surgeon can then utilize to make small adjustments to the hip prosthesis to get the best possible outcome for each patient. So here's how the system works. We take pictures at the beginning of the case with a registration tool, which helps calibrate exactly how many millimeters is this distance from here to here. It tells the software that, so that way it knows how many millimeters across this surface is. And it also allows the computer software to analyze exactly what is your offset and leg length preoperatively. And we're going to use that to recreate our hip outcome at the end. As you're inserting the cup, it gives you live digital feedback on exactly what the measurements are of how you're placing that cup position to maximize range of motion and stability for the patient. And then as you're finishing the operation and making minute adjustments to improve the outcomes and make it as natural feeling for the patient as possible, it's telling us here that the leg length is exactly perfect and the hip offset has been changed slightly. So that surgeon will then make changes to the hip prosthesis to make these numbers perfect. Do you want to pause there for any questions, or should we keep going?
I think we can keep going.
Okay. So now with all of those technologies, with all the advanced techniques, that has resulted in really tremendously improved outcomes for hip replacement. And that is why it has been dubbed the operation of the century. So to contrast, historically, patients stayed 3 to 7 days in the hospital. It was likely that a hip replacement patient would require transfusion postoperatively, meaning they lost so much blood during the operation, they actually needed a transfusion to replace what was lost. Frequently, patients had to go to a nursing home or a rehab facility, and that actually was studied, and it was determined that it resulted in a high risk of infection for our patients. Historically, as we discussed, hip precautions were necessary because patients were done from a posterior approach, which meant they had to sleep with a pillow, which was a wedge between their legs. They had to sleep on their back regardless of their preference, which resulted in decreased sleep quality during the recovery phase. They could not cross their legs and they could not bend over. None of those things apply now to modern technology. Also, during the closure, staples were sometimes used, or even visible sutures that had to be taken out, either staples or sutures, during the first postoperative clinic visit, which was a very unpleasant experience for patients. So that is no longer part of the equation anymore. And all of these things put together resulted in slower recovery for the patient. So nowadays, to contrast that, I would say the vast majority of patients are done with what's called same-day surgery, or where they come in the morning, they have their surgery, and they're home by dinner time. This gives the patient the best of both worlds, which means you can recover in the comfort of your home. You don't have to, suffer the hospital food, but you also get outpatient physical therapy, which is done at the clinic which is closest to your home. So that's really the best way to recover from a joint replacement, in my opinion. All the modern technologies that we're using in surgery has resulted in basically non-existent blood transfusions. I mean, I can't remember the last time I had to transfuse a primary, hip or knee replacement, which is pretty phenomenal. There are no range of motion precautions, as we discussed with the anterior-based hip surgery. You can do virtually, within reason, anything you want from day one, as long as it doesn't hurt, by all means, go ahead. I do, in 100% of my joint replacements, what's called a plastic surgery closure. So that means all of the sutures are buried. They're underneath the skin. You will never see any suture. You'll never see any staple on my patient, because those are risk factors for infection, number one. Number two, it results in a very unpleasant patient experience, and we're all about that. All of these things put together result in a much more expedited recovery process for the patient and a better outcome. So what is same-day surgery joint replacement? That basically means you come in the morning, you have your surgery, and you should be home by lunch or dinner. You do get up and walk with physical therapy before you're discharged, obviously, because we don't want the patient to be facing any hurdle upon arriving home that they haven't already successfully demonstrated in the hospital in a safe environment with a physical therapist. So the way it works is, as we said, you arrive for surgery in the morning, you have your surgery, you wake up, you're observed by the clinical staff in the recovery unit, you work with physical therapy, and you're discharged when safe and ready. And that means usually you're home by dinner time. Obviously, if you needed to stay for any reason overnight, we have that capacity as well, but most patients choose to go home. And how is this possible? How is this achieved? So one thing that I think is very helpful is a concept called prehab. And that basically, everybody's familiar with rehab, which occurs after the surgery. Prehab means strengthening those muscles and limbering up the joint ahead of the operation to make sure that those muscles are tuned up and ready to hit the ground running to expedite the recovery process. So a straight leg raise, I think, is the best way to do this on your own at home. Imagine if you're laying flat on a bed or a couch, and then someone's hand is about 2.5 feet above your toes, and you have to kick their hand with your toes, let's say 40, 60 times. And if you do that 2 or 3 times in a day for the months and weeks leading up to the operation. Thank you, madam. Sorry about that. You just wanted to share. So by doing those repetitions, it will help strengthen the muscles and get you ready for surgery. So it will strengthen your quad, which is the anterior thigh muscle. That is what straightens your knee and allows you to walk. It will also strengthen your hip flexors and your core. So if you strengthen your quad, your hip flexors, and your core by doing 40 to 60 straight leg raises twice a day or 3 times a day leading up to your surgery, you will be much expedited in the recovery process, because those muscles are strong and ready to support you as your joint is recovering from surgery. The next thing is really advanced anesthesia protocol. So I have to hand it to our anesthesia providers. and what they've done over the last 10 to 20 years, because they're one of the major predominating factors that allow our patients to undergo same-day surgery. So there's this concept of multimodal pain cocktail. So that means that we use a variety of medications from different categories that attack pain and decrease it and make it tolerable for our patients by using different mechanisms of action. Okay. Go back. Okay. And by using advanced multimodal pain cocktails, it brings down patients' pain to the point where they feel pretty good waking up. An additional mechanism is that during the operation, I have that multimodal pain cocktail in an injection format, and we deliver that to all of the tissues which are surrounding the surgical field that were repaired and reconstructed during the hip or knee replacement, thereby anesthetizing all those tissues and allowing our patient to get up and walk quite quickly after surgery. Another part of the same-day surgery protocol is accelerated rehab protocol. So in the old days, you used to have your surgery and they'd send you upstairs and you just lay there for days and days and days. Well, studies have shown that by accelerating the process at which patients walk, so from the time the surgery is completed to the time the patient first gets up and walks after surgery, by shrinking that time, not only are you accelerating the recovery, you are actually providing a better ultimate outcome at the end of the recovery process for that patient. So that's what we refer to as accelerated rehab protocols. We hit the ground running. You are not a sick patient. You have a sore knee or a sore hip that needed to be replaced. We replaced it, but you don't have to stay in the hospital. The hospitals are generally for sick patients. We just need to do rehab, and that's what we can do on an outpatient basis. So through all of these different mechanisms, we have customized pain control strategies also going home. I generally recommend, and this is unique for each patient, you have to discuss it with your physician, but Tylenol, ibuprofen, alternating as what we call tier 1 pain control. Tier 2 is what we refer to as tramadol, and then tier 3 is oxycodone. So you have 3 different layers of protection for yourself going home with pain control. And most of my patients never even really get to tier 3. I just had a patient today tell me, I think I took 2 pills from tier 3. Everything else has been tier 1 and tier 2. And he's weeks outside of his joint replacement by now. So that's kind of the majority. It's not everybody. There's ups and there's downs, and there's, patients outside of the average. But that is generally the most common scenario. So who is a candidate for same-day surgery? The simple line in the sand that is not, always true, but the general guidance is less than 80 years old. There are some less, there are some older, there are some, that go both ways. So we make adjustments based on what makes most sense and is safest for each patient. We don't want patients that have heart, lung, or kidney conditions or on blood thinners going home the same day, because they just underwent a major operation, which is a reconstruction of one of the largest joints in their body. They had to receive some sort of anesthesia, either a spinal or general anesthesia. And we want to monitor. They're not actually, oddly enough, they're not actually staying in the hospital for the orthopedic concerns. They're staying in the hospital to be monitored for these chronic conditions to make sure that they are not exacerbated having gone through an operation. So oddly enough, it's the medicine doctors and the internal medicine doctors that are doing the most work on the patients that are staying in our hospital, simply because they're being monitored for these conditions here. Other things that are necessary to go home same day from a joint replacement is adequate social support. So either a spouse, a child, a neighbor, a family friend, a church member, someone flying from out of state. All of those are options for social support for the first 2 to 3 days following the operation. And really, I would recommend someone staying with you for 2 to 3 days just to be there supportively, for simple things like, cooking meals, grocery shopping, stuff like that, making sure you take your medicine, just being available to help ease the logistical burden for you for the first 2 to 3 days is generally advisable. I do have patients that do it on their own. I do recommend, even though for those patients, having someone stop in, 2 to 3 times a day just to check in, grocery delivery, things like that. you also have to be physically fit enough to get up and walk. So if a patient has been in a wheelchair for say a year plus leading up to an operation, just because we fix the bone and cartilage aspect of things doesn't mean we're revitalizing their musculature or their strength or their endurance. Those are things that have to be rebuilt over the subsequent weeks and months following the operation and during the recovery. So if you're not physically fit enough to walk down the hall, to get yourself out of a chair, to get yourself out of a bed, to go to the bathroom safely on your own, these are all requirements that we make sure patients pass before discharging them from same-day surgery to leave the hospital. So if you can't do those things preoperatively, you're probably not going to be able to do them postoperatively. And for that reason, you may stay overnight in the hospital if for any reason, a patient couldn't do those. The last factor, we consider is the home environment. So if a patient lives, some of these buildings in DC can be, or in Virginia can be quite crazy, where patients live on the fourth, fifth, or sixth floor, and there's not always a reliable elevator that's safe. I'm not going to send a patient home and say, yeah, just go ahead and do 6 flights of stairs the first day. It's not going to happen. Sometimes those patients will go stay with a friend or a family member that has a livable space on the first or second floor. That's an option. But if they don't have anyone that has that option for them, staying overnight in the hospital or even a rehab stay is sometimes a possibility. But I will say the vast majority of patients are candidates for joint replacement. I would say 80 to 90% of joint replacements go home same day, and very, very few go to a rehab or nursing home. I would say maybe 1 to 2%. And you would be shocked that there's there's a lot of patients that say, I live alone, I can't do this, I really need to go to a nursing home or to a rehab facility. And about 9 times out of 10, they get there and they say, get me out of here. I want to go home. I feel fine. My knee is sore, my hip is sore, but I just want to be in my own home. That is like the vast majority of patients that go to a rehab facility. Not all the time. There are certain special circumstances, but I will say that's the general experience. So in terms of the recovery pathway, I like to explain it like this, because everybody knows what these buildings look like. After 1 to 2 weeks of the surgery, you should be able to walk around to CVS or Walgreens, no problem. After 3 to 5 weeks, you should be able to tackle Target or Walmart. And 6 to 8 weeks, you should be able to walk around Costco or Sam's Club. So that's kind of the recovery process. You will be up and walking within hours of your surgery, but it does take some time for the swelling and pain to go down and your endurance to be rebuilt. And that's kind of the pathway that I would expect for most patients. Sometimes this is all crunched down into like 2 to 4 weeks. Sometimes it goes all the way up to 12 weeks. Every patient is a little bit different in terms of how they recover, but by and large, this is kind of the average experience.
How does that recovery matter for knee replacements? We're having a lot of questions on that.
Yeah, absolutely. So it looks like we have some time. I actually have another talk similar to this one about knee replacement, so we can do that now if you want. Knee replacement, I would say, if you add 1 to 3 weeks onto each one of these numbers, that's what you get with knee replacement. And the reason is that that joint is more complex. It's not one compartment like the ball and sock of the hip. It's actually 3 different compartments with many more ligaments, which provide stability. Those ligaments do not like being operated or worked on. And during the recovery phase, we need physical therapy and rehabilitation to get those ligaments softened up and moving again. Otherwise, we have a knee replacement, which looks great on x-ray, but doesn't really move well for the patient. So that rehab process to get those ligaments softened up and moving again, that's the hardest part of knee replacement.
Okay, thanks. Are we into nurse navigators yet, or what's our next?
Yes. Yeah. So I just had a summary of what we talked about. We talked about, arthritis, mild, moderate, severe, what that looks like, what that feels like. We talked about direct anterior hip replacements. We talked about robotics, artificial intelligence, and other software packages and joint replacement as like kind of the next phase of things. And then we talked about same-day surgery and improved outcomes. And just to give you a brief overview, we have clinics in Arlington, Ballston on Glebe Road, and then also clinics in Fairfax near the main campus of what we call ICPH, on Innovation Drive in Woodburn and Fairfax area. And now nurse navigators.
Michelle, why don't you take the lead here real quick?
All right. Um, First, looking at this slide, I wanted to take a minute to kind of brag about something that I am really proud of. Our joint replacement program at Inova. So 4 of our 5 Inova hospitals have earned the prestigious designation as Centers of Excellence for hip and knee replacement by the Joint Commission. What does that mean? Simply put, we are committed to delivering the highest quality evidence-based care to help our patients achieve the best possible outcomes. What truly sets us apart, aside from this designation, aside from our expert surgeons such as Dr. Lingamfelter, it's the care team that is going to support you each step of the way. From the moment you decide to have surgery, all the way to your recovery, when you get home, you'll have a dedicated team that's guiding you, that's advocating for you. And one key piece of that team is our nurse navigators. My name is Michelle Hall, as I was introduced earlier, and Brittany Smith is also here. Brittany is at Fair Oaks Hospital, and I am at Mount Vernon. Our role as nurse navigators is to be your go-to person throughout your joint replacement journey. If you're scheduled for surgery at Inova, you'll hear from a nurse navigator very shortly after you book your procedure. We're here to make you feel informed, confident, and well prepared before your surgery and supported throughout your recovery. We are not just here for logistics. We are here for you. Oh, I'm sorry. You want to move the slides, Dr. Lingamfelter? Thank you.
Yes.
Just one more, I think. There we are. Our focus is on advocacy, education, and making sure that your care is seamless from the start to the finish, like I said before. We'll help coordinate things from pre-op prep to discharge planning and beyond. Our team, as you see here, there's 4 of us. We also have a couple of outpatient nurse navigators that are not pictured here. All of us are highly experienced. We've been nurses for a long time. Nursing is what we love to do. We love supporting our patients. And many of us are also specialty certified in orthopedics and post-anesthesia care. I'll say at the end of the day, our goal is simple. We want you to feel ready going into your surgery, supported during your stay, and empowered to enjoy life with your new joint. Does anyone have any questions specifically for us, Kevin? I think Dr. Lingamfelter did a great job explaining same-day surgery and all that stuff.
Yeah. So here's what we're gonna do. We're gonna go through some. So we will just to bridge a quick question here. We will have additional ATs throughout the year, including one specifically on knees, just shortly after the summer. But we will tackle all knee questions in the queue tonight. And if we have time, and if Dr. Lingamfelter is open, he might do a quick summary of the differences between the two. But you'll notice that there's a lot of similarities. That's why we didn't dive into the whole thing double over. So we're going to go through some rapid fire questions, then general replacement surgery questions. I have them all kind of in a row. And then we will jump into the knees. So if everyone wants to hang, just know if you're here specific for knees, just give it another like 10 minutes and we'll be right there. And up until then, we're going to answer questions that really probably go for everybody. Michelle, while you're still not on mute, just answer this quick one real quick. If you don't have family support or another support group, can you still be considered for hip replacement surgery? How would you handle post-op recovery in that scenario? I think that's a great nurse navigator question.
And Dr. Lingamfelter touched on this a little bit. Of course, we still want you to have joint replacement surgery, but a huge piece is that you have support. I know that a lot of people don't want to ask for help, but in this instance, you should ask for help, and I am sure that you have people that can support you. There are a lot of community resources, church support if you do go to a church.
No.
It is possible. And we will help you plan, home health like we mentioned, or rehab in the rarest of cases, but we are all here to help you coordinate having enough support.
That's excellent. Okay, now let's dive into some rapid fire. Dr. Lingamfelter, get ready. Feel free to just say yes, no. This one's going to be, these are all like fun questions. And we're going to start. Has artificial cartilage been developed so it could be inserted in knee or hip replacements?
No. Artificial cartilage, basically the only successful technology is what you see right here, which is a hip replacement. They have tried many, many, many different ways of inserting alternative tissues. there is to date no successful way to interpose new cartilage without reconstructing the joint.
What about 3D printed replacement parts? Is that something being done currently?
So when you hear about 3D printed technology, generally that's applied to knee replacements, actually. So when you say, for example, that this is a hip replacement here, but when the bone is resected or cut in this very precise fashion, it's called an osteotomy. There are many, many more osteotomies involved in a knee replacement as compared to a hip. So when you're making those little cuts in the bone and you hear people talk about 3D printers incorporated into that procedure, it means that a cutting jig was 3D printed for your unique anatomy. It sits on your bone and it gives your surgeon a very accurate and precise resection or cutting plane. That's generally how 3D printing fits into joint replacement. The reason that we don't really custom 3D print implants like the metal parts themselves is that you want consistency. You don't want, a batch of one inserted into your body. You want to be one of millions of implants that have a 30+ year track record of excellent success. So that's why we don't 3D print the implants themselves, but we do 3D print some technology around knee replacement. And that's generally how it works.
You mentioned OrthoGrid earlier, and someone asked, is that something you are using currently or any other Inova surgeons?
Yeah, absolutely. So OrthoGrid is available. There's also another system called Velis, which is from DePuy. So there's three really, the biggest implant manufacturers in the country are Stryker, Zimmer, and DePuy. And Stryker is famous for robotic technology. Zimmer and DePuy are famous for the OrthoGrid, like AI type software packages. So we have access to those at Inova facilities and we use them all the time.
There was another one. Someone read an NIH study about robotic surgery needing more revisions than a manual THR. Is that something you've read up on? Can you even touch on that, or would you need some time?
No. So by and large, robotic hip replacements are more successful at recreating the perfect, alignment of the cup and the stem. In my perspective, robotic hip replacements, as we study them, moving forward in the decades, we will probably demonstrate that the robotic hip replacements are going to last longer because all of the biomechanics of the reconstruction are more optimal for easy and smooth operation of the hip.
Excellent. So let's keep going through. Some of these are going to be a little bit more towards individual. So some of the questions might just be for some folks, but let's talk about knee and hip replacements for individuals that are might have congestive heart failure, and then on this a different part of the spectrum. But we're talking about limitations. Let's talk about just general weight limitations and individuals that feel like they might not be able to get hip or knee replacement.
Yeah, both great questions. So congestive heart failure and heart conditions in general, basically when we're considering the possibility of a joint replacement, we're looking through all of the patient's past medical history. Anytime a cardiac diagnosis is listed, we automatically send that patient to be evaluated by a cardiologist. 9 times out of 10, they know a cardiologist because they have an established diagnosis, and we simply communicate with that provider to ensure that that provider, the cardiologist, agrees that this patient is safe and has a green light for an elective hip replacement or knee replacement. In terms of weight, so there's this concept of BMI. It's a number which is calculated based on your height versus your weight, and it can range anywhere from 15 to 45. 15 is like the skinniest person you've ever seen in your life. 45 would be the opposite. So a lot of studies have looked at where is it safe to have a hip replacement or a knee replacement in that range. Most surgeons will draw a cutoff at 45. And the reason is that many, many different studies have illustrated that by going above 45 in terms of joint replacement, hip or knee, it is somewhere between 4 to 6 times as likely to have an adverse outcome and basically a negative experience with the joint replacement as compared to having that patient lose weight and coming down to a BMI of in the high 30s or 40s where it's safe. So if you go online, it's actually, I think it's the Center for Disease or something. There, if you just Google BMI calculator, you'll be able to punch your numbers in and kind of figure out your height versus your weight. What BMI number do you get? If it's below 45, generally speaking, you're a candidate for joint replacement. If you're above 45 or even in the 40 range, I would recommend doing what you can to bringing your number down into the 30s. And that's because I want the best possible outcome for every patient we do surgery on. And by optimizing what we call preoperative risk factors, diabetes, weight, pain control, by optimizing those factors, we're improving the chances and getting dialed in so that we can say we're doing everything we possibly can to make sure that you have a great outcome from the surgery.
Two more on that subject. Two things that might limit surgery: lymphedema, and then what about being on blood thinners?
Great question. So blood thinners are pretty straightforward. Each medication has what's called a half-life, and that means there's a certain amount of time that you have to stop the medication before the operation to have that medication totally out of your system and basically a non-factor for the operation. Warfarin is somewhere around 7 to 10 days. You've got Eliquis, which is like 2 to 3, Xarelto, which is like 24 to 48 hours. So each medication has a certain amount of time in that window that we have to incorporate. In terms of lymphedema, I just had a patient within the last month that had really significant lymphedema, actually. So there are certain specialized techniques. Number one, it's a conversation with you and the surgeon ahead of the operation. Is this patient safe for surgery? We definitely don't want any cracks in the skin, blisters, anything like that in the leg that we're doing surgery on. And the reason is that any crack in the skin can allow bacteria to our surgical site as it's recovering and cause a problem. So lymphedema, which is basically swelling in the ankles and the feet and the calves, can stretch those tissues and increase the likelihood of that happening. So by being very careful in the way the operation and the recovery is proceeded with, we can minimize the chances of that happening. One of the most important tools for that is actually compressive stockings. And we utilized those recently that were put on as soon as the operation was done while the patient was asleep on the table. The compressive hose went on and it goes from the patient's toes all the way up to their groin. And it helps reduce and prevent swelling from occurring in the calf, ankle, and foot and reduce the chances that a blister could occur and cause a problem. Additionally, lots of elevation. It sounds simple, but elevation is actually one of the most key effective strategies at reducing swelling after a hip or knee replacement. So if you combine compressive stockings, elevation, and ice, 9 times out of 10, you can eliminate lymphedema as a problem, but it is a conversation you should have with your surgeon ahead of the operation.
All right, we're going to keep rapid fire. This one, how long before you're driving post-hip?
6 weeks.
Knee?
6 weeks.
Okay. How far apart do the surgeries need to be to replace both hips?
Great question. So it can be as short as 2 weeks. It can be as long as a year. As long as you're sturdy and strong enough to stand on the hip we just did, then you're ready to go for the next one.
How about your knees?
Also 2 weeks to a year.
Okay. Can you speak on the pros and cons of a second, I guess it's a follow-on hip replacement?
Like a second go-around type surgery, it sounds like.
Yeah.
So yeah, absolutely. So primary surgery is what's referred to as going from your native hip, which has arthritis, to your first hip replacement. I believe this question would be referring to going from this hip replacement to another one if there was ever a problem with this one. It is, very rarely necessary. It depends on the patient factors. There are several reasons why that could occur. And I'm actually a specialist in converting patients from primary to revision surgery. Anyone that's achieved a fellowship and is board certified in joint replacement is a specialist in doing so. And basically, we're handling the most complex, not the simplest ones where you're starting from normal anatomy, but ones that have had surgery that unfortunately did not succeed for one reason or another and needed to be converted to another one. We do that all the time, and we're basically experts in it. So there's lots of different reasons, but I don't want to get too much into the weeds on the details. But yes, it can be done, and very rarely is necessary.
Can you speak on hip replacements where ossification has occurred? This happened to one of our prospective patients, and they were told nothing could be done.
Great question. So what they're referring to, I believe, is a condition called heterotopic ossification, or HO. That is a condition where after the operation is concluded and you're converted from your arthritic hip to a reconstructed hip, for whatever reason, there's many different factors, but the muscles and soft tissue around the hip can actually be stressed and respond to that stress by forming bone. And that bone is occupying this empty space that should be allowing range of motion. And if that empty space is not empty, if it's occupied by bone, it results in reduced range of motion and really significant pain. So that is exceedingly rare. It happens less than in like 1% of patients. It's more common in the outliers in terms of anatomy and complexity of cases, because those cases tend to be longer and more stressful on the muscle. Things can be done actually. So it can be treated. There are protocols. It usually takes some time, but I'd be happy to talk to them about it in the clinic.
Thanks for that. I think at this point we're going to move a little bit more to knee. That's pretty much all of our hip questions. I know we've dedicated a lot of this to hip. Dr. Lingamfelter, do you want to do like maybe a quick just synopsis on the differences? Nothing too over the top. And then we've got about 8 questions left, and individuals that might still have knee questions that were hanging around, this is the time. Throw them in the chat, and we will try to get to them as long as Dr. Lingamfelter's available.
Absolutely. So I'll go briefly through this here. Play from current slide. So briefly, this is mild arthritis. You can see there's still some space left. This is moderate. The space is becoming more narrow. There's more bone spurs involved. And this is a knee that needs to be replaced. Going back just to give you an idea, so the 3 compartments we talked about in knee replacement are the inside weight-bearing knuckle, the outside weight-bearing knuckle, and where the kneecap touches the femur. Those are the 3 compartments that are reconstructed in a total knee replacement. That's hip stuff there. So this is what a total knee replacement looks like. Total knee is really a misnomer. And I kind of hate that term, to be honest with you, because when you say total knee to a patient or they hear that term, they think you're replacing everything from the thigh to the shin bone, basically. And that couldn't be further from what we're trying to achieve. We're trying to achieve as minimal bony resection as possible while taking away the patient's pain. So all of the exposed bone, which has been damaged from arthritis over the years, we replace that with metal. And the amount of bone that we remove is exactly down to the millimeter, is exactly the same dimension as this implant here. So the end of the bone is shaved off with those osteotomies. You can see that there's multiple osteotomies in each plane. And then this metal component fits precisely over the end of that bone, your femur, your long bone. And then a base plate is put at the top of your shin bone, your tibia. And similar to a hip replacement, between the 2 metal hard surfaces is what's called polyethylene. And that's the artificial cartilage that allows a friction-free surface to be utilized for the knee. Underneath the kneecap, if the kneecap is worn out, we also replace that with polyethylene. These are those ligaments that I was telling you guys, are really important to the balance of the knee. These green ligaments on the outside are what football players love to tear up. Your MCL, your ACL, you got your PCL and your ACL in the back. Those ligaments, you can think of them as like the suspension of the knee, if you will, and they provide constraint and integrity to the knee joint itself. A successful knee replacement is all about achieving optimal tension on those collateral ligaments so that the knee feels safe and smooth and stable for the patient and also more natural. The way that we achieve that is taking a knee which has become bent over time with arthritis and making it straight again. Patients always ask, is my knee going to be straight when you wake up? It better be, because that's our whole job there, is to restore the anatomy of your knee, which is straight. This is an example of robotic technology. So for a lot of different reasons, robotic technology is much more successful in knee replacements and achieving an outcome where these ligaments are appropriately balanced. So I use robotic technology in 100% of my knee replacements to make that a reality for them. So this is an example of an operation with one of my mentors from the Rothman Institute. We published this in the Journal of Arthroplasty today, describing our technique for joint replacement with robotic knee replacement with robotic technology. So the surgeon here is using that probe we mentioned before to take the virtual software image. Let me go to that laser and map that onto the real life anatomy of this patient's bone using these array checkpoints to make sure that we are very safe and we are accurate down to the millimeter. And that's what this is showing us here. Then you have a plan which is being tested during the operation to ensure that those ligaments are perfectly balanced for that patient. And these are what we call MPSs, or Mako product specialists, who are interacting with the software on the part of the surgeon based on his instruction, adjusting that plan during the operation to get the best possible outcome for that patient's knee replacement, down to the millimeter, actually down to half a millimeter or half of a degree. This is the tool that is being used by the surgeon to make those cuts on the bone and accurately place that knee replacement so it's perfect for each patient. And as you can see, the surgeon is controlling this entire thing. This robotic arm will not even turn on unless he's holding it appropriately and conducting the surgery himself. And he has an assistant who is holding the knee to ensure that it's protected and safe during the operation. So this is an example of an outcome from a knee replacement where we balanced the inside and the outside of the knee down to the millimeter to make it as perfect for that patient as possible. And this is what the outcome is a resurfacing of the end of the femur with the femoral component, a replaced kneecap, and a replaced tibial base plate. And robotic technology results in really accurate bony resection to place this component extremely precisely, personalized anatomic alignment based on those collateral ligaments and your unique anatomy, which results in improved ligament balance and a reproducible native feel or more natural feeling knee for the patient. It also results in less bony resection because we know exactly where the knee needs to go for each patient. So we just make one cut and we're done. It also results in really efficient planning because we have the preoperative CT, the bony model of this patient. So we know exactly what size they need. And all of these things combined result in really high patient outcomes for total knee replacement. This is a partial knee replacement. If you only have arthritis on the inside, why fix the other two if they're looking good? We just replace the inside. Generally speaking, this is for younger, more active patients that haven't had arthritis set in the other two components. This is another type of partial knee replacement, simply for the kneecap and the groove. But all operations are provide great outcomes for the patient. It is only determined by what is best for each individual patient and their condition of arthritis. And that's pretty much it for knee replacement.
Yeah, well, there's some really good questions, and I think you did a pretty good job. And I think you can see the similarities. Let's start off things. There was an individual that had a partial knee years and years ago. It seems to be failing. What are the options?
Absolutely. So one reason I love partial knees is that converting from a partial knee to a total knee is very simple. It's almost as easy as going from a native knee with no surgery to a total knee. It's almost as easy as doing that. So that's why I love doing partial knee replacements, because, in my mind, it's a question of what's most important for the patient. But if you do a partial knee and you have really excellent outcome, and you're really physically active and it enables you to run or jog or do whatever your activity is, and that lasts another 3, 5, 10, 15 years, then you just had an additional number of years where you had a very natural feeling knee, and it reduced the recovery process. And then converting, as you alluded to, from a partial knee to a total knee replacement, super easy, super simple. We do it all the time. So it's generally quite straightforward.
If you had a torn ACL, so again, those things that suspend the knee, and lots of arthritis, will knee replacement result in less swelling and a more stable knee?
Yes, absolutely. So patients that have reconstructed ACL, generally that reconstruction of the ACL will attenuate and stretch out and basically become incompetent over decades. And I know because my dad had both of his ACLs repaired after he tore them playing football in Texas in high school. And by the time he hit 45, 50, he needed to have both of his knees replaced because they were so unstable. He couldn't walk down the stairs or walk down a hill without almost falling over. Now he can do that with his knee replacements because the way the knee replacement is designed is to accommodate for any deficient ACL and provide a more stable joint.
So here's a question. Actually, this came up, I think, like from four different people. Do varicose veins affect a total knee replacement?
No, and similar to lymphedema, we use the similar strategies, compression stockings, elevation, and ice to make sure that we don't have any blistering or cuts or scrapes in the skin to minimize the risk of infection. And by using those three techniques, generally it's not an issue.
This is a fun one. People say that this individual said that people say that there's more pain after a knee replacement.
So I will qualify that in saying that there is more pain for a short period of time. So if you compare a knee that has arthritis to a knee replacement 1 week after the operation, you're going to have more pain 1 week after the operation than you did before. But if you compare an arthritic knee to a knee replacement, which is, 6, 8 weeks, 12 weeks, 16 weeks down the road, the knee replacement will win 99% of the time. So that's why I say, the recovery process from a knee replacement is much more difficult and strenuous on the patient as compared to a hip, which is quite easy and straightforward. The knee replacement, you have an uphill battle at first to get through the recovery and the rehabilitation. And then after 3 to 4 weeks, those symptoms taper off quite considerably. But I joke with patients in the clinic at their 2-week visit, and I always say, we're going to be friends again here real soon. It's just going to take some time to get through the recovery phase.
Any relationship between a knee replacement and possible pain in the buttocks and mobility later after surgery?
No, not really. So pain in the buttocks is mostly associated with muscle, tendon, ligament, and also your lumbar spine mechanics. So when patients come in with pain in the buttock, it's so counterintuitive, but doing hip and knee replacement as we do, all day, every day, when a patient comes in and saying my hip hurts, but they point to their buttock, 9 times out of 10, it has nothing to do with your hip. It's one of those other problems going on.
Is osteoporosis a problem in knee replacements or hip replacements?
It is concern, actually. So we test 100% of my patients, and most surgeons' patients are tested for vitamin D and calcium deficiencies, and those deficiencies are addressed and corrected prior to the operation. So if you're vitamin D deficient or calcium deficient, we give you supplementation during the recovery phase to make sure that your bone has everything it needs to heal appropriately. It also changes the way we conduct the surgery sometimes. So if you're installing a hip or a knee replacement in someone, let's say, that has osteoporosis or osteopenia, we're much more careful in the way we interact with the bone because we know that it's been, demineralized in a certain amount. So we're much more careful in the way we proceed with surgery. It doesn't change much in terms of the outcomes, though. And from the patient's perspective, a knee replacement is a knee replacement, a hip replacement is a hip replacement. So it doesn't change the outcome, but it changes the way the surgeon handles the bone with a little bit more delicate nature.
Another good one, knee related, but to both. The available hardware will cover all possible patients' dimensions. Are there any size limitations?
That's a great question. So one of the remarkable benefits of robotic surgery and also just really accurate preoperative planning is that CT scan is accurate down to 0.5 millimeter. So I know exactly what size knee or hip replacement we need going into the operation. There are, people on the end of the bell curve, shall we say, where we bring in specialized instrumentation like a size 1 or a size 0 or all the way up to like a size 7 or size 8, 9, 10. Those are very, very rare, and I could probably count on one hand the number of times we have to do that in a year. But one of the benefits of preoperative planning is we identify those patients well in advance, and we are well prepared for those scenarios so that it's not an issue in the operation.
All right, and then Dr. Lingamfelter, if you don't mind going to your final slide so everyone can see your contact information. But a final question that came in to me, and then if anyone has anything additional, please let me know. But comment on the advantages of subvastus technique knee replacement. Do you do this procedure? And then people were asking about minimally invasive as well. Maybe that's a good time to talk about both.
Yeah, absolutely. So when you do a knee replacement, it depends on which way you approach the knee. So there's something called mid-vastus or subvastus, and there's called medial parapatellar. It has to do with how you approach the knee deep to the skin and get through that tissue called the capsule. And they've studied mid-vastus, subvastus, parapatellar, and for the most part, those outcomes are similar. If a patient has a preference, I'm happy to pursue whichever one they prefer. But for the most part, in terms of knee replacement, most of the time the outcomes are similar for all of those. In certain special clinical scenarios, one might be more favorable than the other, but it really has to do with each individual patient. And then what was the second part of the question?
Minimally invasive, and someone's even asking about scars for both as well. So if you want to go on a roll.
Yeah, absolutely. So for knee replacement, by using robotic technology, we can make the scar smaller. And obviously for hip replacement, because we're doing surgery from an anterior-based approach, the incisions are much shorter and more minimally invasive.
And then I guess the final one coming in was, what's the recovery time for a partial versus a total?
Yeah, so a partial knee replacement does recover at a more expedited rate because you're only affecting 1/3 of the compartments in the knee. So that means less swelling, less recovery time in terms of that. So, those numbers that we went through, I think that was up here. Sorry. Right there. So if these numbers we went through, you could basically divide each one in half, and that would be the recovery of a partial knee replacement. And partial, total, both are great operations. It really depends on what type of arthritis is uniquely present in your knee, and your surgeon will help kind of indicate which one is the best.
Excellent. Well, if you want to go again to your final slide, I want to thank Dr. Lingamfelter for joining us. I think we learned a lot this evening. Obviously, there was a lot to take in because we even tackled knee on top of hip. I think even going between both of them, which was phenomenal. Everyone will receive a follow-up email with a link to the video of today's webinar. And just a reminder, there's the direct way to contact Dr. Lingamfelter. There's this little guy. I don't think he's allowed surgery.
Sorry, he was the interrupting, not invited participant,
but hopefully a future surgeon. We could use plenty more in the DC area. Again, thank you, Dr. Lingamfelter, for giving time away from family tonight. Michelle, Brittany, and our entire nurse navigating staff is waiting for anyone that's looking to do a joint replacement in Inova, and they will help guide you through what seems like a crazy process, but they turn it into just the simplest, easiest thing that, again, you might hopefully go home same day. So,
and our contact information I placed in the chat. So depending on which location you're looking at, which hospital, all of the navigators are listed in the chat and their email addresses. That will be helpful for you. Please reach out.
Wonderful. Thank you guys so much for your time. Thank you for attending. Thank you, Michelle and Brittany. I really appreciate your time and all the wonderful work you guys do. It's tremendous.
You're the best. Thank you.
Thanks, everyone. Have a wonderful evening. Appreciate your time tonight.